So tonight we're covering OBGYN stuff. Not emergencies we see very often, but important stuff to know. So first, some A and P. So female genitalia, diagram right there. You've got ovaries, fallopian tubes, also called oviducts, uterus, cervix, vagina. It includes external genitalia and internal genitalia. So you've got the vagina or birth canal, ovaries and fallopian tubes, which carry the eggs. Fallopian tubes are where fertilization usually occurs. And an ectopic pregnancy, which we'll talk about later, is any pregnancy that occurs outside of the fallopian tube and then uterus. You got the uterus. It's a muscular hollow organ located midline in a woman's lower abdominal quadrants, the intended site for a fertilized egg to implant and develop. The uterus can stretch and grow as the fetus gets larger. You've got the cervix, which is the muscular ring separating the uterus from the vagina. The reproductive cycle for menstruation, stimulated by hormones, estrogen and progesterone. Ovaries release the egg, uterine walls thicken, the egg moves along the fallopian tubes. If there isn't any fertilization, then the uterine walls and egg are expelled, which is bleeding for about 3 to 5 days. If there is fertilization, that's when sperm reaches the ovum becomes an embryo implants in the uterus, and then you start fetal development. So physiologic changes in pregnancy. 9 months of pregnancy, generally broken into three-month trimesters. Got the placenta that develops. It's an organ of maternal and fetal tissues, and it's the exchange area between the mother and fetus, exchanging oxygen and nutrients. You've got the umbilical cord, which circulates blood, connecting the fetus or baby to the placenta, and it will also come out during delivery. You've got the amniotic sac that contains fluid that allows the fetus to float, provides protection, cushions it. It also helps control temperature. So, picture of it there. And if anyone has questions at any point, just feel free to jump in. So changes that occur during pregnancy, for the cardiovascular system, you're going to have increased blood volume, as the mother's providing blood for the infant as well, increased cardiac output, increased heart rate. Respiratory system, there's going to be increased oxygen demand and consumption. GI system, often there'll be nausea and vomiting, slow digestion. Hormones, ligaments are going to be made more elastic to allow for the growth, but also means increased chance of injury. Additional weight will affect posture, possibly leading to back pain and balance issues. And certain pre-existing medical conditions might show themselves and or get worse. So picture there showing, talk about, you might see increased blood volume, which may show with flushed skin. Shortness of breath might be common because of the increased oxygen demand. The growing fetus and changing uterus size will be shown by the large abdomen. You'll be able to tell a faster pulse. The stretched ligaments, the extra weight, you'll see them often standing kind of in a sway back posture, complaining of back pain. So there's something called supine hypotensive syndrome. So the placenta, infant, amniotic fluid can weigh 20 to 24 pounds. If the pregnant woman is laying flat, that compresses the inferior vena cava, which runs kind of along the spine, and can prevent blood flow, which and can cause them dizziness or drop in blood pressure. So does anyone know how we prevent that? Anyone? So if we lay a woman on her back and she starts feeling like she's going to pass out, what do we do?
Isn't it put her on her left side?
Yep. Yeah, so by kind of tilting her off to the side, then that will shift the weight instead of like going straight down off the side, allowing for the blood return.
Left lateral recumbent.
Yeah. If someone's backboarded, you can just, place maybe blankets under the backboard, tilt them to the side. Sometimes you can shift, kind of just like take their abdomen, shift off to the side, but that should help. Does anyone here assisted or watched a delivery, either of your own kids or in the field? See a couple hands. All right. So there's 3 stages of labor. First stage starts with regular contractions and ends when the cervix is fully dilated. Second stage is when the baby enters the birth canal through when it's born. And the third stage starts after the baby's born and it ends when the placenta is delivered. Someone will have Braxton Hicks contractions that are irregular, not sustained, and not indicative of impending delivery. Lightning, fetus will start moving from higher in the abdomen down towards the birth canal. Contraction of the uterus will generally produce labor pains. Characteristics of the labor pains, you're going to measure the interval and duration of them, so how long they last and how far apart they are. When they're lasting about 30 seconds to a minute and are about 2 to 3 minutes apart, then you might expect delivery to be imminent. If they're further apart, then you assume that you might have time. So this will be important when you're determining whether or not we're going to deliver a kid on scene or whether we're going to try and make it to the hospital. Breaking of the amniotic sac, i.e. water breaking. You might see fluid that's stained with meconium. So if it's kind of brownish tinged or whatever, that may be a sign of fetal distress. All right. So that was the first stage. Second stage, that's when they're fully dilated. Contractions are going to be increasingly frequent. Labor pain is going to get worse. Mother should start to feel an urge to push or move her bowels. And this is where you're going to have to decide whether to transport or keep her where she is and prepare to assist with delivery. Okay, so second stage, go from fully dilated through delivery. Then the third stage is after birth. After the baby's birth, contractions will resume until the placenta is delivered, and that may last about 10 to 20 minutes. That's a picture of the placenta being delivered. Talking about patient assessment. Assessment, like if you find a woman in labor, assessment is going to be focused on whether the delivery is imminent. So, of course, we'll get our name, age, expected due date. Find out whether it's a first pregnancy or whether they've had multiple pregnancies. If they've seen a doctor and received prenatal care, and then when did the labor pains start? I'm going to ask them if they feel an urge to push or move their bowels. And then we'll do an examination. So we'll look for signs of crowning. We'll feel the uterine contractions and make sure we get vital signs. So if delivery is imminent, then we're going to assist with delivery. So starting with assisting delivering the head. Findings that might indicate need for resuscitation after delivery. If they haven't received any prenatal care, so if they haven't been seeing a doctor during their pregnancy, the infant's going to have a greater chance of complications. If the baby's premature, so if we find out their due date and the baby's quite early, greater chance that we're going to need to be involved. The labor was induced by trauma, so something traumatic causing them to go into labor, or multiple births, say if they're having twins, triplets, or such. Other findings might be history of pregnancy problems. So if there have been complications during this pregnancy, or with previous pregnancies, if labor was induced by drug use, or if you notice any of the meconium staining when the water breaks. For normal childbirth, just remember, like, we aren't the ones delivering babies. Essentially, it's the moms. We're just there to assist. Primary role is going to be figuring out whether or not we think we're going to deliver on scene or whether there's enough time to get to the hospital. So if we are going to deliver on scene, control the scene, make sure we're wearing appropriate PPE. We can put the mom on the bed, floor, or an ambulance stretcher. We're going to remove any clothing blocking the vagina. We're going to get an assistant, make sure we've got some people to help us, and go get an OB kit. If possible, make it as warm as possible. If you've got some towels, these are some ways you can drape them, just to try and want to provide a little bit of privacy and some comfort. Make sure you got your OB kit out and ready. If you don't have access to enough towels, you can use clean sheets. Yeah, we shouldn't need to worry about that. Someone's going to need to be in constant view of the vaginal opening, watching for crowning. Realize that the patient's going to be in a lot of discomfort and be prepared for that. Provide emotional support and encouragement. Communicate with the patient through all their contractions. So someone will be at the mother's head, then someone will be down assisting with delivery. So as the head starts to appear, you're going to have gloved hands ready. As soon as the baby's head bulges out, you're going to place a hand on it to prevent a very sudden or abrupt delivery. And then you're going to help guide it out, and then place one hand beneath the head as it delivers, support the head. If the amniotic sac has not broken at this time, you can use your finger to puncture it and move it out of the way. As the head delivers, you're also going to look to see if the umbilical cord is wrapped around the baby's neck. This is not uncommon, but is generally very easy to just slip off their neck and generally doesn't result in any lasting complications. Then you'll help kind of guide the shoulders out, whole time supporting the baby. Then we'll assess the airway, and if needed, you can use a syringe, like the bulb syringe, to suction the mouth and nose, and then note the time of birth. So a picture of supporting the head, then helping guide out the shoulders, support the trunk, support the pelvis and lower extremities. All right, and now we sort of have two patients. As soon as the baby's born, we've got both the mother and the newborn to worry about. So as soon as they're born, we're going to assess them, looking for ease of breathing, heart rate, crying, movement, skin color. An APGAR score we generally want to do after birth and then a few minutes later. So it stands for appearance, pulse, grimace, activity, and respiratory effort. And that should be, I believe, in our protocol. So if you don't remember what it is, just look it up. So 1 minute after birth and 5 minutes later per our protocol. And then, I don't know, you can see, but that's the APGAR score in our protocol. So hopefully everyone has the protocols downloaded on their phone. I reference them every now and then, especially when there's calls like, say, treating a pregnant patient or a pediatric that I don't do very often. I like being able to reference it. All right. So assessing them may be necessary to stimulate the newborn to breathe. So flicking their heels, rubbing them, going to keep them warm. Heat retention is a very high priority. So we're going to dry them, get rid of the wet blankets, wrap them in dry blankets, cover the head. Generally, we'll cut the umbilical cord well after the, probably about a minute after delivery. You may need to do it if it's wrapped around the baby's neck and you can't get it over, slide it over. So we'll keep them warm. We'll use sterile clamps or umbilical tape, one about 10 inches away, and the baby one about 7 inches away for the clamps, and then cut in between. And then afterwards, once you've got the baby dried off, wrapped, you can place it on the mother's abdomen. All right, so that's a picture showing of where you put the 2 clamps and then cut in the middle. So why is it important to stimulate a newborn? What's stimulating help them do?
Maybe breathing or?
Mm-hmm. Yeah, that helps prompt them breathing. So hopefully you stimulate them and you'll start hearing them cry. So, all right, so provide warmth, assess the airway, and establish that the baby is breathing. So you're gonna look at respirations, heart rate, and muscle tone. If the respirations are shallow, slow, gasping, or absent, you're going to provide positive pressure ventilation at 40 to 60 per minute. So remember that newborns are going to be breathing much faster than your adult, but they also don't need a lot of air. So it's not going to be squeezing a massive bag. It's going to be lots of fast little breaths. We're going to assess their heart rate. If it's less than 100, you're going to provide ventilations. For adults, generally a cardiac arrest is going to be induced by a cardiac cause, say a heart attack. But for infants, it's often tied to a breathing issue. So we're going to generally try and treat a heart rate issue by breathing for them. So if their heart rate's less than 100, provide ventilations. Hopefully their heart rate comes up. If it's less than 60, we're going to start compressions. Even before they go into a true cardiac arrest, we'll start compressions. If respirations and pulse are adequate, then we'll just reassess as needed. So resuscitation process, first drying, warming, positioning, suctioning, trying to stimulate them, providing oxygen, bag valve, ventilation, intubation, and then or chest compressions. Then the ALS stuff would be intubation and medications. If we are doing CPR chest compressions, we'll be delivered mid-sternum with 2 thumbs and wrapped around the chest at a depth of 1/3 to 1/2 the depth of the chest. For very small infants, your thumbs may be overlapped. So what was our first steps in neonatal resuscitation? What are some of the things we might need to do?
Stimulation.
Stimulate them. What else if their heart rate's is more than 60 but less than 100? Yep, see, access the airway. So if their heart rate's between 60 and 100, what are we going to do? Yep, we'll provide artificial ventilations. If their heart rate is below 60, what are we going to start doing? Yep, CPR. Oh. So what's central cyanosis? You don't know? So what's the central part mean?
Cyanosis in the torso. And
Yep.
Yep.
Yeah. So it kind of goes with APGAR score, which we didn't go into detail, but like a full rating on color of a newborn would be if they're completely pink. That would give them the 2. A 1 would be if just their extremities are blue, and then a 0 would be if they're blue throughout. So like if the central cyanosis is a sign of worse oxygenation than say just their extremities or hands. So what was the ventilation rate that we were going to use for a newborn? How many breaths per minute? Anyone remember?
Someone say 20?
You can say it.
20? 20?
Yeah, so 40 to 60, so it's pretty fast. All right, so care after delivery. So we've got both the mother and the infant to care for. The mother is going to be at risk potentially for serious bleeding, for infection, embolized. They may have a heart attack afterwards. You need to assist with delivering the placenta, trying to control bleeding, as well as providing comfort. So the placenta will deliver with the umbilical cord, amniotic sac, membranes, tissues lining uterus. May take longer than 30 minutes, but we can begin transport before that happens. One way to help control bleeding after delivery of the placenta is to massage the uterus. That helps it contract and can help reduce bleeding. Controlling bleeding, we're just going to place dressings over the vaginal opening. We're not going to pack it inside. Have the mother lower her legs and keep them together but not squeeze them. Massaging the uterus will help it contract, which controls bleeding, as well as having the mother nurse the baby also helps reduce bleeding. And to make sure we take vital signs frequently. Also be kind and supportive. Because generally if everything went well, this is a pretty life-changing experience for them, so make sure we're being a good part of it. You can help wipe her face, hands with a damp washcloth, give her clean sheets and blankets afterwards. However, sometimes there's going to be complications. Common ones may be cord around the neck, an unbroken amniotic sac, infants who need encouragement to breathe. There's also something called breech presentation. That's when something besides the head presents itself. You might see a butt first, you might see legs first, potentially even an arm. In these cases, risk of birth trauma to the baby is high. So like in this case, delivering feet first. There's limb presentation, so you might see a limb like a foot or a hand. If they're in breech, then you might see the feet. So this one, if they're butt first, we might be able to deliver at home. But if you see just a foot or just a hand, we can't deliver them in the pre-hospital setting, so we need rapid transport. So something like this. So if you see just a foot, or especially if you see just a hand, they're not in a good position to deliver. Prolapsed umbilical cord is when the cord presents first, and then the cord will get squeezed between the vaginal wall and the baby's head. So that will interrupt blood flow to the infant and can be potentially life-threatening. So in this case, our goal is to take pressure off of the cord. So you might have the moms like keep her hips elevated, administer oxygen, keep her warm, and then essentially have someone put their hands in and try and lift the baby's head off of the cord. So we're not going to push the cord back in. and we're going to keep it moist and just try and keep pressure off of the cord and transport rapidly. If it's known to be twins, triplets, or such, make sure we've got appropriate resources to deal with multiple newborns. Clamp and tie cord of first baby, assist with delivery of the second. Placenta and cord care are going to be the same as well. Make sure we keep babies and mother warm. Premature birth, again, keeping warm. It's very important. Keep the airway clear, provide ventilations or chest compressions as needed. Watch umbilical cord bleeding, avoid contamination. And in these cases, definitely let the emergency department know what you're coming in with so they can have the appropriate resources ready. Meconium will be staining amniotic fluid green or brownish yellow in color. We're going to suction the airway before we stimulate the infant to breathe. May need to provide, again, ventilations or chest compressions, transport as soon as possible. Emergencies we may have to deal with, excessive bleeding pre-birth, ectopic pregnancy, seizures in pregnancy, miscarriage or abortion, trauma, stillbirths, and cardiac arrest of pregnant women. For excessive pre-birth bleeding, main sign is usually going to be profuse bleeding. They may or may not have abdominal pain. We'll be looking for signs of shock. We'll provide oxygen and other treatments for shock. If we do see bleeding, we'll place dressings or sanitary napkin. And we will, if there's tissue that's been passed, we will save that in case it was a miscarriage. An ectopic pregnancy is a pregnancy that develops outside of the uterus. So that might be acute abdominal pain, that might be referred to the shoulder, vaginal bleeding, rapid weak pulse, low blood pressure, and an absent menstrual period. So essentially, be concerned for this potentially with any woman of childbearing age could be at risk of an ectopic pregnancy. Some women develop seizures during pregnancy, visiting preeclampsia. So if they've got an elevated blood pressure, you might see excessive weight gain, swelling hands, ankles, hands and feet. They may develop an altered mental status, headache, other unusual neurologic findings. So they may have the warning signs of preeclampsia that hopefully they're being treated for to prevent them from developing full-on seizures. Miscarriage or abortion, they can be spontaneous, sometimes it just happens, or induced. Will probably come with cramping and abdominal pain. Bleeding can range from moderate to severe, and there should be a noticeable discharge of tissue and blood. Trauma in pregnant patients, their pulse is generally going to be 10 to 15 beats faster per minute than non-pregnant women. Blood loss may be 30 to 35% before signs of shock appear. So just because it seems like they're doing all right doesn't mean that they're going to stay that way. So ask any trauma patient whether they received any blows or injuries to the abdomen. Stillbirths, do not resuscitate if it's obvious that the baby has died sometime before birth. Provide full resuscitation measures if baby is born in pulmonary cardiac arrest. Be prepared to provide life support. And if resuscitation is unsuccessful or we decide not to resuscitate, make sure we're providing emotional support for the family. Cardiac arrest of a pregnant woman. There is some chance to save the unborn child even if we are unable to save the mother. So you can displace the uterus, so kind of shift it out of the way if they're more than 20 weeks long. You're going to probably move your hands 1 to 2 inches higher on the sternum because the heart shifts as the uterus grows. Continue CPR to the hospital until there's a chance for an emergency C-section or the ER takes over. So this is going to be the case where we would transport a code versus most of the time we either get pulses back then transport or declare a death on scene, but it will be different in the case of a pregnant patient. Gynecological emergencies. There might be vaginal bleeding not related to a pregnancy. Treat it as potentially life-threatening. Check for associated abdominal pain. Monitor for hypovolemic shock. Trauma to external genitalia. Observe the mechanisms of the injury. Look for signs of severe blood loss. And consider if there's external injuries, there's potential for internal injuries. Sexual assault, first and foremost, we're going to treat any immediate life threats. We'll do our best not to disturb any potential criminal evidence. Only if there's severe bleeding present do we need to actually examine genitals. Discourage them from bathing, going to the bathroom, or cleansing wounds, because that can be evidence. And then take care of any required reporting or investigatory needs. So what are some things, if we are showing up to a sexual crime scene, that we might want to pay attention to or think about?
Scene safety.
Yep, so our scene safety, yep, before we even enter.
Try and provide some privacy for the victim.
Mm-hmm. Yep. It may be, if there's a female EMT or paramedic, that might be best, or at least someone present. Don't do the questioning examination necessarily in front of all the crowd of officers and family and whoever may be present. Anything else?
You wouldn't want to touch anything that you don't need to, or disturb anything that's in the room.
Yep. In the room or the victim themselves. Don't avoid disturbing anything, and also be very observant, because there's a chance that you would, your observations, your chart, whatever, like they may ask, like part of the investigation might be asking you what you saw. So be aware of certain things. Perfect. All right, so in review, birth is a natural process that generally takes place without complications. And generally our role, if it's happening, is it might be someone who's had multiple children already, and so their deliveries, instead of being hours of labor, are pretty fast, and we're there because they just didn't have time to make it to the hospital, and we just sort of assist and everything goes fine. But there's times that things can go wrong, and then that's where we get more involved. EMT's role at birth is generally just to provide reassurance and assist the mother during delivery. During normal delivery, we're going to evaluate the mother, determine if there needs to be immediate transport or if birth is imminent and will take place at the scene. If we're going to deliver on scene, make sure we've got our equipment ready and appropriate resources. Sometimes this might mean calling another engine, calling another ambulance. Always be prepared for resuscitation. Complications of delivery or true emergency, need to be prepared for rapid transport. In case of breech presentation, a prolapsed umbilical cord, limb presentation, premature birth, or meconium staining. Also can have pre-delivery emergencies, or emergencies associated with pregnancy, such as excessive bleeding, an ectopic pregnancy, seizures, abortion, trauma, that we need to be prepared to treat. Stillbirth, death of the mother, and sexual assault are going to be difficult emergencies for us that we may be called upon to manage. So providing emotional care is incredibly important to the patient, especially once we've taken care of any life threats. Our emotional care that we provide might be more important than any additional medical care. And then we need to make sure we also provide emotional care for ourselves, because these can be pretty tough calls to deal with. Female reproductive organs present new anatomy and specific potential emergencies, recognize the differences, and be prepared to address any reproductive emergencies. A growing fetus creates massive changes to the mother's body. All systems from cardiovascular, respiratory, GI undergo pretty significant changes during pregnancy. Assessment of women labor is designed to predict imminent delivery and recognize chances for neonatal resuscitation needs. Urge to push and crowning indicate imminent delivery. In that case, we should probably hold off on delivery or hold off on transport. Lack of prenatal care, premature labor, multiple gestation, and underlying conditions indicate a likelihood that we may need to be involved in neonatal resuscitation. Remember that childbirth requires a high level of PPE. It's a pretty messy process. Most important aspect of care for the neonate is keeping the baby warm. Resuscitation may be indicated by assessing breathing and heart rate. After delivery, make sure remember there are 2 patients to care for, the infant and the mother. To be familiar with pathophysiology and emergency treatment of various complications. Care of the sexual assault patient must include medical, legal, and psychological considerations. All right, so we didn't really talk about it, but what's the difference between abruptio placenta and placenta previa? Does anyone know?
Is abruptio placenta where it actually separates, and then placenta previa is that where it's just attached in a strange spot?
Yeah.
Okay.
Yeah, so abruptio placenta generally occurs in the 3rd trimester when it separates prematurely from the uterine wall and will lead to bleeding. So, because it hasn't yet separated as it's supposed to. So that can cause significant bleeding. And then placenta previa is when it, instead of being kind of at the top and back of the uterus, it's down covering the cervical opening. So that can prevent delivery and result in bleeding. And hopefully abruptio placenta, they may not know if it's placenta previa. Hopefully if they've received care, that will be identified ahead of time. But the abruptio placenta could happen unknowing and cause significant bleeding. So if we see a prolapsed cord, so if the cord presents first, what are we going to do?
Try to keep pressure off the cord and rapid transport.
Yep. Yeah. So someone's job is going to have their hand essentially on the baby's head, trying to lift it off of the cord and transport as fast as we can. If the amniotic sac is still intact during delivery,
You'd break it.
all right, so we're called to a pregnant woman in labor. During evaluation, we find it's the woman's first pregnancy. Upon inspection, the baby's head is not crowning and contractions are about 10 minutes apart. Ask the mother if she feels the need to push. She says no. You think we're going to deliver on scene or transport to a hospital?
Transport.
Yep, transport, because we're assuming we've got time. All right. And that is it. So any questions on OBGYN stuff? Okay. Everyone's hold on, I'm going to try and write down everyone's name to make sure I've got attendance taken. Anyone been on any good calls recently? Anything interesting?
Yeah, Cassie, this is Bill. Have you done any deliveries yourself?
I have not. That is one medical. Part of paramedic school was spending a couple shifts in labor and delivery, so I watched a couple, which was the most miraculous and like disgusting thing I've ever seen. Um, there was tearing and bleeding and pooping, and but then there's new life. So it was. But there's some people here who, in the same amount of time I've been here, who have like had multiple deliveries. Most of them, I think, have just gone well. Just was happening too fast to get to the hospital. I remember think if it was Peter, someone had.
I had two in a row.
You had two in a row?
With Adam Bryce. We welcomed Washougal lives into the fold. The first one was a explosive delivery. She was in the frame of the door and delivered the baby right there. So I walked up and she had already ejected the baby, so I just had to do everything from there on. Warm the baby, clamp the cord, cut the cord, get mom skin to skin, and breastfeeding if you can. That helps control the bleeding as well.
Mm-hmm.
The second one, Bryce and I had the pleasure of delivering a baby in a bathtub. I guess the good part is it's easier to clean, but again, I was just the unfortunate catcher at that point. So I'd say I was more of a assistant and assisted instead of directed something that's been going on for millions of years. I don't need to interrupt that.